So, yeah, that's of course easier with open surgery. You don't need a screen. You don't need a lot of technique. But still, there's a lot of options that you can do with pincer treatment with hip arthroscopy. If you look at the different cases, of course, it's not always such a simple case where you have a very, very focal pincer type deformity that you can just take away with the burr and you're done with surgery. So the first technical trick is certainly to assess the X-ray as you do it in open surgery. Arthroscopy is just a tool. It's not a treatment. It's a tool where you can achieve the correction, and of course you have to choose the right indication and have to know exactly what you're planning. Moritz Tannast demonstrated this in a very good overview, and I always assess these angles before I do surgery and do planning. There are a lot of planning tools available, and when we talk about pincer, we talk about overcoverage. So the aim is to reach a normalized hip morphometry, and this is one of the planning tools I use, and I want to know exactly what correction I have to achieve to normalize the hip. And this can be done in this way with the anterior wall in red, the posterior wall in blue, and the LCE angle. You measure the acetabular index, and you want to know exactly what correction you want to achieve in hip arthroscopy. Of course, the overview is a little worse compared to the open surgery, so you want to know exactly what correction you achieve and what amount of bone you have to take away. In this case, to normalize the lateral coverage, you have to take away 6 millimeters of bone, and this you can, of course, then control with the image intensifier. Of course, if you have a tool like Chris Peters, that makes it also much easier for hip arthroscopy. But still, the image intensifier is a very, very important tool that you should use appropriately when doing any kind of hip arthroscopy and bony corrections. So, regarding the image intensifier, you have to be well aware that the image intensifier is an AP hip view and not an AP pelvis. So the X-ray beam has a projection that significantly influences the crossover sign and the anterior and posterior coverage. With the image intensifier focused on the hip, you have an image like this in a pelvic X-ray that looks like this. So you underestimate the anterior coverage and the crossover, and that of course puts you at risk to undercorrect any anterior focal pincer deformity. What you can do, you can of course calculate the beam according to this calculation, which usually results in approximately an inclination of 5 degrees towards the contralateral hip to give you a true AP view of like you see it on the pelvis. That's how it looks like. So I always try to have the same projection as I have on the pelvic X-ray. Regarding patient selection, we've heard a lot about the power of surgical hip dislocation to correct global deformities. What we can treat very well with arthroscopy are focal pincer deformities, global pincer deformities, and of course torsional deformities, which you also have to consider cannot be treated. In this case, in my experience, it's not a good case for hip arthroscopy. You can reach a lot with hip arthroscopy. If you see this case with this ossified labrum, the cartilage was relatively good, but of course here at the rim it was gone, the labrum was ossified, and you see the correction on the left side. You can go with the posterior lateral portal, you can go relatively far, and if you use a posterior portal you can even go further, but that always depends on your experience and if you want to decide to do open surgery and surgical hip dislocation. Consider torsional deformities. This is a very nice image from Simon Steppacher, which demonstrate that excessive antetorsion and anteversion, as well as retrotorsion of the femur and retroversion, can cause femoroacetabular impingement that is similar to pincer type impingement with this very sharp impingement at the acetabular edge, which of course cannot be treated arthroscopically. Furthermore, we often see, and that was the case of my talk also yesterday, we often see pathologic morphologies, which don't mean that we have a pathology. So you have to decide, do we just have a pincer morphology, or do we have really pincer-type femoroacetabular impingement? And with the pincer-type impingement, we often see labrum changes. So you want to look arthroscopically, are there any labrum changes which guide the treatment for pincer treatment, or do I have a completely healthy labrum? Typically, labrum changes are tears, are degeneration, hematoma, and bleeding, ossification, fraying. And if you see this, then it guides you also to the treatment of pincer-type deformities. If you have a case like this with a mixed-type deformity, a very mild pincer deformity, and you have just a chondrolabral damage like this and a completely fine labrum, of course you have to think, do you really want to detach that healthy labrum, trim the rim and refix it, which will give rise to adhesions and scarring in this area? Or do you just treat the cam resection? If you have a very smooth, impingement-free range of motion, then certainly you don't, in my opinion, you don't have or should not address the pincer if it's mild. Regarding the technical trips during surgery, anesthesia and fluid management is quite crucial. Pincer treatment arthroscopically takes usually a little more time, and of course, you need some kind of capsulotomy, which gives rise to fluid extravasation. So you should have the systolic blood pressure below 100 millimeter Hg to reduce the blood pressure that you need for the resection. You should control the abdominal pressure from time to time, and dual wave arthroscopy pumps with a pressure-controlled suction, of course, make it a lot easier to keep the pressure within the joint without having a lot of bleeding. Patient positioning is crucial because if you just pull on the leg that you're doing surgery on, the pelvis might tilt and you have a negative acetabular roof, and that will make it a lot more difficult to get into the central compartment. So if you apply a little bit of traction on the contralateral limb, that will help you to keep the pelvis stable. There are alternative techniques like a post stabilizing the iliac crest, or even scoping without the post, like it has been published by Maidan in more than 1,000 hip arthroscopies. That's certainly a very special technique. And something that is probably underestimated is the Trendelenburg position that reduces the pressure on the perineal post with 50 degrees of Trendelenburg by nearly 50%. So that's a very, very powerful tool to reduce the pressure on the post and give you a better access with reducing the risk of perineal and groin-associated complications. Of course, if you go into Trendelenburg position, you again have to adjust the image intensifier because this will give you a more inlet view of the pelvis. So the image intensifier has to be adjusted. How do we access the central compartment? I usually do central first, but in pincer cases I do peripheral first because the central compartment is difficult to access. You see it in this case from the peripheral compartment, you see the labrum, you see the femoral neck. There's not a lot of room to get into the joint, and you have a high risk of labral perforation and cartilage damage. And if you do a little bit of capsulotomy, this will improve the joint distraction. And then with the joint distraction, like in the lower image here, with a blunt instrument, you can go into the joint without damaging the cartilage and the labrum. If you just see this image intensifier image on the left, you would think, well, the labrum is probably perforated. I won't go in centrally first with such an image, but under view, you can see that the labrum is well preserved. Use as many portals as necessary. I have to hurry up, the battery is running out. You should use as many portals as you need to get a good overview and and reach all the pincer areas that you need to reach. I use the distal anterolateral portal especially for the anchor placement and do the resection with the other portals. Reduce the traction time and the traction, access the labrum from the peripheral compartment. There's a lot you can do from the peripheral compartment. You can test for stability of the labrum. You can do part of the resection. You can remove calcifications. And you can also start to clear the perilabral space without traction. What you see here with the labrum and the pincer deformity that is already prepared for resection. And then you can also start rim trimming as much as possible without traction, reverse reaming to protect the labrum. And I often do this over the top technique without previous detachment of the labrum to create a nice rim correction. If you have a very small labrum, you might have to mobilize it with a banana knife, because otherwise you will resect the labrum probably with the burr. But in these cases, you can mobilize it and get a very nice overview of the acetabular rim. Depending if you keep the chondrolabral, if the chondrolabral junction is intact or not, you might proceed to over-the-top reaming, or might prefer to detach the labrum and fix it again. So that depends on the size of the labrum and on the chondrolabral junction. There's one more thing to consider, certainly. These are these cases with a very prominent anterior inferior iliac spine that might project over the acetabular rim and give you the image of a pincer type deformity, which is not the case. If you see a very distal bump, that's usually the contact between the iliac spine and the femoral neck, very distally, and you can already assess on the AP pelvis the anterior wall and the anterior inferior iliac spine, which is very well visible on sagittal MRIs or on full profile views. And these you can correct and should correct after capsulotomy. Here you see the labrum, here you see the anterior inferior iliac spine and the rectus insertion. And you shouldn't remove more than 8 to 9 millimeters to not detach the rectus femoris, and then you can create a very nice anterior wall and subspine decompression. I don't want to talk too much about labrum fixation. That's certainly a different talk. I prefer to do like a single back-stich loop, which is a loop, and one suture is shuttled through the loop, and by this you have the chance to really rotate the labrum if you pull on one loop or on the other. Depending on the size of the labrum, you might punch the labrum or you might loop the labrum. That's how it works. You get a loop around the labrum, then you shuttle one suture, and this gives you a very nice control of the labrum position. So I nearly made it with the battery. Technical tips for pincer impingement is planning. There are a lot of planning tools available that really make it easier and safer for you to plan it, and you should inclinate the image intensifier to have a real AP view of like it's projected in the pelvis to do the correct resection. Consider the subspine impingement as an additional pathology that should be treated. Patient selection is also crucial, with mainly focusing on focal pincer deformities. But you should also decide, is it a pincer morphology or really a pathology? Is the labrum intact or not? Patient positioning and anesthesia. Trendelenburg reduces significantly by nearly 50% the pressure on the perineal post, what is quite a lot, and the blood pressure should be kept below 100 millimeter. The access peripher first is my suggestion, which is much safer, protects the labrum and the cartilage, and uses many portals as necessary. It's much more soft tissue sparing if you use one portal more than to mobilize all the soft tissue to spare portals. Minimize traction and traction time. There's a lot you can do without traction, and you should use this opportunity. And finally, you should, of course, treat the concurrent chondrolabral damage, always trying to preserve the labrum, and you can do a lot with this over-the-top resection before you detach the labrum. Thank you.